So we're going to begin with the systematic examination of the newborn, the SAIN marking criteria. Okay, I'll read for you this. There are only 8 actually. The thing is long, but there are only 8. So, cleanse hands. Number 1 is cleanse hands with alcohol and hand rub, and washes with soap and water. Dries with paper towels, following WHO guidelines. Explains the purpose of the systematic examination and the screening program. Okay, gains consent from the mother. 3A, ensures the correct environment: warm, light, flat, firm surface, infant alongside the mother. Remember I told you the mother should be watching everything you're doing to the baby. Okay. 3B, reviews the case history and identifies the risk factors. 4, involves the mother in assessing the health and well-being of the newborn, providing an ongoing explanation of the process and the findings. Okay. 5, undertakes a historic assessment of the systematic examination of the newborn. This includes feeding, passing urine, opening bowels. We mentioned all that. Okay. Selected key area 1, heart or hips. So complete assessment to be carried out, including a special access to a special area. Remember, we did the heart, then we did the hips. So the heart with those APTM, apartment M 2245. Then you add bicuspid too. Okay. Then the selected key 2 areas, eyes or testes. I think I will have to go through the eyes or testes specifically if there are areas of concern, and complete the assessment carried out, including special aspects of the special area. 6, accurately documents the examination of the newborn and dates and signs the newborn health assessment document. Has a logical process of the examination. Acts professionally throughout the procedure according to the NMC 2018 and the Code of Professional Standards, practice for and behavior for nurses, midwives, and nursing associates. Okay, so I think let me do that detail. Sorry, this is going to be a long video, but we need to do the details so that we finish this once and go, so you know what to do if they ask you specifically the eyes and the eyes or the hips, and then either. Hi lovelies, welcome back to my channel. So if you're new, click the subscribe button. If you are a returning subscriber, please, thank you for watching, and keep watching. I'm still sharing more information with you here, so when you click the subscribe button, you'll be notified whenever I post. Okay, let's support each other. Let's gang in, ask questions of whatever you want to know, what you want clarity about. I'll be happy to reply. Okay, so this is Sarah, and we're going to discuss about NIPE. NIPE. It's the newborn and infant physical examination in full. Okay, so I don't know, I think at some point we need to demonstrate. This is my baby. This baby is called who? What's your name? Should we name her Lila? She's Layla. So she's Layla. Layla has no clothes today, but I think we shall use her for some parts that need to be explained. So we all know that the NIPE is a linked station. Okay, so what should we go with? What should we start with? Just as we go this, we do the first steps first. So assess the scene for safety. Make sure there is nothing on the floor, no water or anything, that can cause slips, trips, or falls. Okay, so it's the safe to approach. Okay, then do hand washing according to the WHO. There are 8 steps. We've been through that. You can, if you've been watching my previous videos, you know we've talked about the 8 steps of hand hygiene. Okay, then you do the PPE, the gloves, and the apron. Then we go on to say hello. My name is Sarah. I'm going to be the midwife looking after you today. Can you confirm your name and date of birth, please? So the mother may say, my name is Jamira. Date of birth is 12th January 1994. My hospital number is this. I can see you have a wristband. Can I please check your wristband, please? So you check against the name of the mother's told you, against the wristband. It's usually white. Okay, can I confirm with the baby's wristband against your wristband? So you check baby off. Okay, and you compare. Then that's the initial steps. Then you're going to go on and explain to the mother that, okay, Jamira, today I'll do a routine head to toe examination of your baby. It is supposed to be completed within 72 hours of birth, and it's a screening test, not a diagnostic test. So what does this mean? This means I'm not going to be able to diagnose anything. I'll just be able to identify any risk factors which need a referral. Okay, so this will be documented in your baby's red book and on our local system and the national NIPE smart system. Are you happy for me to proceed? That's gaining consent. Okay, then I will ensure that the mother has a private place, so you close curtains and all that adjacent windows and in private and safe area. Then you make sure the baby is safe. Check on the baby. Where are you going to put the baby? Make sure the place you're going to put the baby is a flat, warm. It is a flat, firm, warm area with enough light. Okay, and the mother should be able to see as you're examining the baby, and the mother should be will also be free to ask any questions as they come, as she pleases. Okay, so you confirm with your examiner if you have such a place that you're going to put the baby, the warmth, flat, light, safe area. Okay, then you ask the mother if she has any concerns about the baby before you begin. Then you tell her, you feel free, you don't have to answer me now, you may ask me questions as we go on. Okay, so now we're going to then you explain to her, Jamira, the purpose of this examination, you're going to tell the examiner, for the purpose of this examination, I have read the maternal and newborn history document, such as the family history. I have any risk factors relating to the eyes, heart, hips, and testes, and what is the overall health of my baby. Okay, so she may tell you the baby is okay, generally okay. So apart from the history, then so you begin. Okay, then you begin with, you expose the part that you're going to examine, and then you say, generally the baby looks pink. I can't see any bluish extremities or on the lips, and there's no yellowing of the skin or sclera, therefore the baby does not have jaundice. Mommy, is the baby waking up to feed? Are they alert? Are they active? Do they feed? If mommy says baby is always crying, advise to do skin to skin. Okay, so we're going to start on our full full examination. With full examination, then we're going to begin on the head. So when we look at the fetal head, there is no signs of abnormality. Okay. When I palpate the head, I do not feel no bumps, no sollenness, and there are no obvious signs of cephalohematoma or caput succedaneum, and the head is normal in shape. Okay, I'm going to take a tape measure and measure the circumference of the baby's head from the occiput to the sinciput. Okay. Madam Examiner, I'll put my recordings, so you record what you've got, and then you also, to the examiner, you'll get your recordings later when you finish, okay? Then we go on to the ears. The ears are two. They are symmetrical, well positioned, not low set. The pinna is present, and the cartilage is also present. There is no discharge seen. Okay, and this makes me confirm that my baby's ears are okay. They are patent and no signs of skin tags. Okay, then we go, after the ears, we're going to go to the eyes. So the eyes are two in number. They are symmetrical. They are well aligned. The ears, there are no signs of low set ears and eyes. Okay, the space between the two eyes is normal. The eyes are present. They are well positioned. The iris is visible. Do you see that black part? That's the iris. So we've been talking about our eyes, that the iris, but a big cut. Okay. The iris is visible in the eye, and the sclera is white. There are no obvious signs of hemorrhage, of scleral hemorrhage, and the conjunctiva is pink. Okay, they are not yellow, so no signs of obvious jaundice. Then I'll get my red light if this is the area of concern. So I'll get my red light and look into the eyes. I'll look into the eyes, and that's called the red light reflex. So you switch it on and flash directly into the eye and at an arm's length from the baby, and if it is present, and also you'll do the same on the other eye. If the eyes are low set and the distance between the two eyes is big or so spaced, I'll suspect that there is Down syndrome. Okay, but my baby's eyes are okay. Then we shall go on. If the red light reflex is not present, I will immediately refer the baby to the ophthalmologist to rule out congenital cataract. That is the major cause of blindness in children. If it is severe, the doctor may consider a surgery immediately. If it's not severe, the doctor may consider observing the baby for review after 6 weeks or reassess after 7 days. Still on the eyes, there are no signs of jaundice since the sclera is not yellow. You know, I mentioned that already and I'm repeating it. My baby, my baby. Okay, now let's go to the nose. So you'll get your finger this. Can you put it? So that you feel for the breath. Then, so you say the baby has a nose, it's symmetrical, it's well positioned, the nostrils are patent. So that shows the nostrils are patent when you put your finger here and you feel the breathing. I can feel the baby's breath on my finger, and the septum is one and present. So which means there is a septum, so the nose is well. Okay. Then we shall talk about the mouth. The mouth is well positioned. It has two lips. There is no signs of dehydration. The mucous membranes are pink, and there is presence of the rooting reflex. So you stroke like that, and then just check the rooting reflex. Okay, so you'll tap your finger on the baby's side of the mouth. Now on the baby's cheek, and see if the baby like that's how it is for the rooting reflex. So I'll turn towards you. That's how we test for the rooting reflex. So then you ask the mother, may I kindly insert my finger into the mouth of your baby to check for the suckling reflex? If the mother says yes, you're going to change your gloves, put on clean gloves, and insert your small finger into the baby's mouth to see if the baby can gently suck. Okay, suck the finger. So what are we testing? It is the suckling reflex. The baby will do that. So the suckling reflex is present if the baby does that. So I'll go ahead and palpate for the soft and hard palate. Okay, to rule out if there is any openings or the cleft palate. So this is the hard palate up. Use still the finger you're using, and you feel the hard palate, there is no opening. I'll put for the soft palate. So write your findings. I'll go ahead and observe if there is any tongue tie under the tongue. When there is a tongue tie, the baby is not able to lift their tongue properly. They'll be crying like concealed, because it will be here. So that's the tongue tie. So you should check the baby does not have that. Sorry, I'm using the baby and me because the baby cannot open their mouth. So so I'm trying to examine according to that. Okay, so we'll look at the tongue to see there are no obvious signs of oral candidiasis. So if the mother had candida during pregnancy, the baby may come with oral thrush. It's whitish all over the tongue. So as you see, my tongue is pink. The baby's tongue should be pink too. No signs of oral candidiasis. So then you use the tongue depressor. The tongue depressor is flat, so that you're able to see the ovula. Yeah, to see that the ovula is that. No, the ovula is that. It's unseen. Okay, then you ask permission from the mother to use it and find presence of that gargling reflex. That's the gargling reflex. Okay, in view of the ovula. When you press further, the baby will be forced to gag. Okay, so then we go on to examine the arms step by step. No, actually before the arms, let's examine the neck. So what do we examine at the neck? We shall palpate to see if there are any swollen lymph nodes and the neck is not webbed. In case the baby's neck is webbed, that may be a sign of Down's syndrome. Okay, then we shall go on to the arms. They are 2 in number and equal in size and length. Okay, when you stretch them like this, those ones can't be stretched. They're equal in size and length. There are 2 palms. Each palm has 1, 2, 3, 4, 5 fingers. 1, 2, 3, 4, 5 fingers. Okay, and they are not webbed, and they have 2 palmar creases. Palmar creases are these. So the babies, there are always 2 that are visible. So then you go ahead and palpate for the radial artery. Sorry. Yeah, I shall palpate the radial artery and coordinate it with the femoral artery. The femoral artery is formed here. So so the femoral artery should be pulsating the same way as the radial artery. Then they should have the same rhythm, strong, and have the same rhythm, two. In case there's an alteration in the rhythm, then that means there may be an abnormality. Okay, then we go on to say there are no extra fingers, and the fingers are not partly united or abnormal, but my baby's finger is bent, this one. So my baby has an abnormality, has a curved finger. One of the fingers is curved. Do you see it? Okay, we're done with the arm. So when we go on to the chest, I'll look at the size, shape of the chest, if it's symmetrical. When you observe, the chest is clear. There is no bruising, there is no birthmark, and no swellings on the chest. And there is no labored breathing when you look at the abdomen. So when you count the baby's respirations on the abdomen, you'll see that they range between 40 to 60 beats per minute. Then I'll go ahead and listen to the heartbeat. So I will listen to the arterial, pulmonary, mitral, tricuspid. Okay, so this is what I wanted to explain. Explain. So there is something I wanted to explain. So what formula do we use for this? So it is APTM2245. That's an acronym. So it is I don't know if that's clear. Wish I had a mark. P T M. So it is APTM, the arterial, pulmonary, tricuspid, and the mitral. There is also the the bicuspid, which is at the Alps. However, the 2, 2, 4, 5. 2, 2, 4, 5. Yes. So 2, 2. The 2, 2 is this. They're located on the second intercostal space. This is on the right second intercostal space. This is on the left second intercostal space. Okay, then when you come down to the tricuspid, it is on the lower left sternal border. Lower left sternal border, and then on the fourth intercostal space. Then when you go down to the mitral, which is in the mid-clavicular, which is on the fifth intercostal space. So that makes the APTM. Then you, yes, so then we the bicuspid, which is called sometimes the Alps point, which is on the lower right sternal border. So this is the right. This is the right. The bicuspid is here, tricuspid is here, the mitral is here, atrium is here, pulmonary is here, and the mitral is down here. Understood? If you need more clarity on that, I can do a detailed one, another one. Okay, so what else on the chest? Yeah, so when you're listening, you're listening for extra heart sounds to rule out any abnormality. If there is any, please refer It's an emergency. Please refer to the whom do you refer to the cardiologist within 24 hours, because some of them are deadly. If the baby may pass on. Okay, so that's it. Then we go on to what else? Sorry about the heart, I think. Then we go, I will check for the capillary refill for 3 seconds, and it should refill 2 to 3 seconds. So I'll lay my hand over the chest, rule out dextrocardia. Dextrocardia is where, you know, the heart is normally on the left. So dextrocardia is where the heart is on the right. Okay, so the heart positioned on the right side of the chest instead of the left is the one called, that is dextrocardia. So you just place your fingers like this, you know, the baby's heartbeat is quite like easily identified, so you'll feel it. Then after that, during 24 hours and prior discharge, we've already pulsated the brachial and the femoral pulses. Abdominal palpations were done with the routine examination, so we'll listen to the heart here. So now let's go on to the baby's abdomen. So when you look at the baby's abdomen, you look at the shape to see if there is no any swelling, any distension, any visible blood veins. Okay, so we should say that there are no signs of esophagus. When you look at the cord, it is well positioned, it's well inserted, there are no signs of infection, and the cord is well stamped, it's not bleeding. Okay, then I'll palpate for the liver, kidney, and spleen. So we know that the liver is on the right. This is the right, so we palpate for the liver from down here. You feel it. Feel the eyes not extended. Then you come on the left side, and then you come and palpate for the spleen. The spleen is on the left side of the abdomen. Palpate and see that it's not extended. Then you palpate for the kidneys from both sides. Kidneys are 2. Okay, so we go on to do the genitalia. The genitalia, we start with the female. When you look at the female, I can see that the labia are not fused, and the clitoris appears in normal size. I can't see any vaginal discharge. However, a white discharge is normal, and a small vaginal bleeding is normal too. Okay, you explain to the mother about that. In case the baby gets a small bleed, it's normal. Okay, it's because of withdrawal of the maternal hormones that the baby gets that bleed, so the mother should not be scared. Okay, then we go on to the boys. Okay, so I will look out for the penis, and it should be at least 2 centimeters. You palpate into the inguinal area. This is the inguinal area to see the presence of the testis, and then you have to palpate the scrotum to see that you have 2 testes there. They should be of reasonable size, equal in size. Okay, and then the scrotum should not have any. The scrotum is the top part where that covers the testis, so the scrotum sac should not have any discoloration. It should have the rugi. The rugi should be present on it, and then if the scrotum is discolored, or if it has any discoloration, that is an emergency, and there should be 1 testis in each scrotum. Okay, then you ask the mother if the baby is passing urine. So the mother will tell you, ask her how many pampers have you changed. Then you also talk about you talk about the penis having a patent urethra, no epispadiasis, or hyperspadiasis. You know what is epispadiasis and hyperspadiasis? Whereby the urethra is either up or down the hole. The urethral opening is either up or down. So hyper is up, epi is down. Okay, then we look at the anus. So sorry, I'm holding this baby badly, but I just want to be able to illustrate. I'm sorry about that. My baby's I'm sorry, I'm not holding it the right way, but you should be able to hold the baby properly, because when you're doing it at this, just that I want it to be able to be visible, but the baby should be on the surface. You shouldn't be lifting up the baby like that. Okay, so we shall go down to the anus and see if it's patent. Also check if there is presence of the anal wink, sphincter, and patency. So you confirm with the mother, has the baby passed any stools? How many pads have you changed? Okay, so ask the mother, how is the stool? Is it, explain to her that the baby will pass the dark stool for 2 or 3 days, for those are 72 hours, and then by the time it will cause it to clear down to the normal yellow stool. Okay, then we go down. If the testis is the place of concern, should I do it here or should I go? Okay, if the testis is the area of concern, how did I miss this? Sorry, I missed it when I was doing it. So if they are bilateral, you should be able to see if the tests are bilateral or undescended nodes. That's an emergency, and the baby should be referred to the neonatologist for more examination, investigations within the first 6 hours of life. If there are any unilateral undescended testes, refer the baby and to the neonatologist, who might suggest that the baby is reviewed within 6 weeks. If given time, it may descend or not. So if it doesn't descend, they may need to do a surgery. Okay, so let's go on to look at the legs. So you stretch out your legs and say this, they are 2 in number, they are equal in size. So the size, you flex them like this. You flex them and you see at the knees to see if they are equal in size. Okay, so each has there are 2 feet, 1 on each side, on each leg, and they have 5 toes. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. The feet are not webbed, though my baby's feet are together. They don't have space. The teeth are not webbed, and there is presence of creases in the toes. So when I pass my finger under the baby's sole, the baby will actively move its legs like, okay. Then I'm going to go ahead and look out for dislocation of the hip. So we know the hip also can be an area of concern. So in the hips test, we have the Barlow's test and the Talani's test. Okay, so you flex the leg. When you're flexing the leg, this hand supports here, these fingers here, and this inside here. So I'll place my 2 fingers on the greater trochanter of my thumb, then my thumb into the inner aspect of the thigh, and then I will move it at 90 degrees away from the baby and bring it back. Like you move it away and bring it back. I don't know if that is visible. let me say you're holding it like this. You move it away and bring it back. Okay, so if it makes a clicking sound, it shows there are signs of dislocation. Then I will hold the leg with my 2 fingers on the outer aspect of the thigh, the thumb inside, apply gentle pressure into the socket, and I'll move it towards the body. Oh my god. Whew. The baby has refused to go down. I think I'm going to get a foldable baby and be able to redo the bellows and mat so that you can easily see, because my baby is not folding. Anyway, you can just watch a video about it, or I'll do a video about the otolani and the bellows test. So begin with the bellows and do the otolani. So I'll gently turn the baby on the side and check on the other heartbeat in between the scapulae, and listen to the breath sounds here between the scapulae, and listen to the breath sounds. Okay, I'll also look at the spinal cord and palpate to see if there's any depression or bumps or any swellings, any hair-like projections or appearance, and look if there is any dimpling of the coccyx, which shows there is a defect on the spinal cord. So then I'll get my baby and perform the moral reflex with consent of the mother. I'll hold the baby and release the baby into my other arm like that. That's the moral. When you do like that, the baby will raise their arms. So that is the moral reflex. Then I'll hold my baby like this. I don't know if you're able to see this. Okay, like this. When you hold the baby and make the baby step, the baby will make baby steps, like try to move. That's how we find the stepping reflex, because this is a firm surface, so the baby will perform primitive steps. So we shall confirm we have the stepping reflex. Then remember everything you confirm, write it down for your notes. Okay, mother, you now give feedback to the mother. Okay, mother, according to the examination findings, I have not identified any risk of congenital abnormality or birth defect, and the same examination will be repeated 6 to 8 weeks by your GP. Okay, we shall give you a review date to go and see the GP, and if you see any problem with the baby, kindly notify us. Do you have any questions? So you let the mother ask you any questions she has. If she doesn't have, then you tell her, okay, Jamila, I'm going to go and do my documentation and I'll get back to you. Okay, here is the call bell. Call me if you have any query. So then you come back. If you finish your documentation, come back and health educate the mother. Then you can tell the mother about changing diapers, feeding, safe sleeping. There are no toys around the baby's bed. Okay, and when the baby is sleeping, they should be facing up. So let's go on and do the specific areas. So the specific areas can be the eyes, the heart, or the hips, and the testes. Okay, so he'll give you one of those. How do you go over each of them? Okay, so when you're given the scenario to perform, you'll be asked to focus on either the eyes, hips, or testes, or the heart. So let's begin with the eyes. For the newborn infant physical examination, that's the NIPE. So what do you think? What if it's negative? What do I do? How is it done? Then when is it done? What is the screening test about? Okay, so how do you answer what is it? So the screening test is to identify or refer any newborn with abnormalities of the eyes. This is to reduce morbidity and mortality of newborns with any congenital abnormalities. When is it done? It is done within 72 hours of birth, and it is repeated 6 to 8 weeks by the GP. Okay? How? Identify any congenital cataract, and then most importantly, look out for the red light reflex, okay, in the newborn. Get maybe, do you know when you take a photo at night and you see that part of the pupil being red? That's how the red light reflex looks like. So we use the ophthalmoscope, and it looks like a brown light. It shows a partial, so it may show partial or no reflex or full reflex. Okay. Also the color of the eyes, like mine are brown. They're symmetrical, there is no any discharge, there's no deviation from the normal. Okay. Then you talk about what do you talk about? You talk about, so when you're doing this, you should also note that before you begin any procedure, you should talk about the consent. You should talk about safety, privacy, and hand washing. Then you gain consent to expose the baby, provide warmth for the baby. As you approach the baby, look around the cot. How is the baby lying? Are there any dolls in the cot? Is the baby lying on the back or no? Okay. Seek consent from the mother about changing the cot to a static. So now let's see the hips as the point of focus. So remember, we have the Otolani and the Ballos test for this. Okay. So in Otolani, the hip is abducted. Gentle pressure is applied to the proximal thigh from behind. Okay. This helps to relocate an already dislocated femoral head back into the acetabulum. Okay. If a dislocated joint, like clacking sound, like crackles, it's noticed the head into place. So what is it? So this procedure is used to identify and refer babies born with any congenital abnormalities of the hip to reduce morbidity and mortality. When it's done within 72 hours of the baby's life, and also it's repeated at 6 to 8 weeks by the GP. Okay. Then how? The examination of the hips requires two maneuvers. That's the Ballos maneuver and the Talani's maneuver. So they look at the dislocated hip and the they look at the dislocatable hip and dislocated hip respectively, which means Ballos maneuver looks at the dislocatable hip. Otolani looks at the dislocated hip. Hope you get me clearly. So then you check the equality of the knees, legs, digits, and any sacral dimple. Remember, for the legs we said you stretch them out and then fold them. At the knees is where you see whether the legs are equal. Okay. The digits, you count everything as you saw what I did first. Then if negative, review the baby at 6 to 8 weeks. If positive, ultrasound scan of the hip. Hello. Then should we go into how fully again? So you expose the lower extremities, bring the two legs together, check the equality, check and count the digits. I can confirm I have equal digits of the feet. Check the knees, check and place the index finger under the baby's knee. Okay, this is what they mean. This is your index finger, place it under baby's knee and do like this. That's what they mean. Under the baby's knee, next to the middle finger of the thigh, and flex it together, place down. Okay. Now on the hip, the Ballos test, flex the knees together, extend the leg towards the right and move back together. Do the same to the leg. sorry. So the otolani is to check for the dislocated hip. You flex the knees together, place one down, move one forward, and you hear the clacking sound. Are we together? Oh my God. Then let's look at the heart. There are 4 things to keep in mind. What is the examination about? When is it done? How? If positive or negative, what's the screening test? Okay. So for the heart, this is to identify and refer babies born with congenital abnormalities of the heart to reduce morbidity and mortality. Okay. So some of the congenital abnormalities we have are heart arteriosis, septal defects, hypoplastic left syndrome, pulmonary atresia, tetralogy of the fallocord, total anomalous pulmonary venous return, tricuspid atresia, truncus arteriosus, and ductus arteriosus. Okay. However, the most common are heart arteriosis, tetralogy of the fallout, and ductus arteriosus when within the 72 hours and after 6 to 8 weeks to the GP. How? Carried out using a stethoscope. Remember, I've told you that ATP, apartment, APTM, then plus the bicuspid, and then the 2, 2, 4, 5. Okay. So we also need to talk about that we are looking at the nasoflaring apnea that's lasting more than 30 minutes as you're doing the examination. Then you also look at the tachypnea, then look at the visible pulsation, the central cyanosis, the murmurs, those are extra heart sounds when you're auscultating. Then the intercostal recession. Yeah. So then you need to explain where you're placing your stethoscope. The mitral valve, pulmonary valve, intercostal space towards the left sternum. This was the aortic intercostal space towards the right sternum. Then the mitral valve is here, mid-clavicle. Then the tricuspid is on the lower left sternum border. Then the bicuspid is on the, tricuspid is on the lower left sternum border. Bicuspid is on the lower right sternum border down there. So you may say like, examiner, I'm going to examine the baby's heart. I'm going to auscultate for the 5 areas to listen for murmurs, extra heart sounds, and I'll also be doing a visual examination of the nose for nasal flaring, the chest for intercostal recession, and central cyanosis. Hello. So I will also be looking out for visible pulsation, tachypnea, and apnea. So I'll start. Jamila, is that okay with you? Okay. So you expose the baby and then you start your examination. You remember to tell the mother, I may be a bit quiet, but don't worry, I'm just trying to listen if there are any additional heart sounds. So do not be worried about it. So I'm going to place my stethoscope on the mitral area, which is located in the mid-clavicle space. I'll ask the examiner if there is any murmurs or extra heart sounds. And place the any heart sounds. Then place the pulmonary area intercostal space towards the left sternum. I will now move to the aortic area at the intercostal space towards the right sternum. Bring it down to the cuspid area, the lower sternum border, and then move to the bicuspid, which is at the lower right sternum border. What if? Positive or negative? What do you do? If positive, emergency, 24-hour referral to the senior pediatrician in depth knowledge of cardiology. Remember, anything concerning the heart is an emergency. It can lead to death of a person anytime. Okay. So, if negative, wait until 6 weeks to be reviewed by the GP. Okay. That's done. So now, if you're given the testis as the area of concern, that's number 3, remaining with 1. So what is the examiner expecting you to say? What is the examination about? The examination, this is a screening test to identify and refer babies with congenital abnormalities of the testis to reduce morbidity and mortality when within 72 hours of birth. and at 6 to 8 weeks with a GP. Okay, how? The examination is going to have a visual of the male genitalia, glands, penis, and the testes. You'll be palpating the testes for undescended testes, bilateral or unilateral. Undescended testes may form a swelling and abnormality. You'll also be looking at the glands, penis for foreskin, shape of the penis, presence of the penis. What if? Positive or negative? If positive, emergency 24-hour referral to rule out metabolic or senior to rule out any metabolic issues, and for the senior pediatrician to review for sex developmental conditions. If negative, review at 6 to 8 weeks with a GP. In addition, should the GP identify a unilateral undescended testis within 6 to 8 weeks, they will require a referral at 4 to 5 months to be reviewed by the GP. If they are bilateral undescended testes, a referral within 2 weeks for another examination will be needed. So remember to do, even if they've been specified someplace, you need to do full examination. And then when you reach the area you're supposed to expound on that. Okay? What is missing? We've done the heart, we've done the testes, we've done the eyes, and what else? Hips we've done. Eyes, yes. Heart. They're all done, darling. So thank you so much for watching. Yeah, it's been such a long day. Thank you for watching. Please subscribe, comment, ask where you need clarity. I'll be happy to reply. Thank you so much. Thank you for watching.